We saw in Corey Harden's superb presentation in this series that treating the lung gently in COVID ARDS is at the heart of superior outcomes for ventilatory patients. However, the key question becomes, how do you keep pressures low in the face of refractory respiratory failure? Dr. Alexandra Wong, a pulmonary and critical care specialist at MGH, answers the question. First, we'll look at lung protection. Second, we'll evaluate an extensive tool set for gauging the effectiveness of escalation. Third, we'll go through an example that pulls these tools together into a streamlined and simple workflow. So first, the key principle is to stretch the alveoli just enough with the right ventilator settings to open up and allow them to function, but not enough to damage them. Dr. Wong uses the example of balloons. You can see the two to the left are underinflated. The third one is just right, and the fourth, to the right, is overstretched and doing more harm than good. Lots of force is necessary to start to open the deflated balloon on the far left, and when the balloon is overstretched on the far right. Now let's translate this into a pressure volume curve to see how this works. The lower curve is inspiration. The upper curve is expiration. The lungs begin to inflate at the very bottom of the curve to the left. Pressure increases without much volume along the y-axis until LIP, or the lower inflection point, where many more alveoli start to recruit as pressure increases and the slope in the line changes. You can liken this to blowing up a balloon for the first time. The initial breath into a balloon is met with lots of resistance until it opens to a critical volume. Then it becomes easy to inflate, which is the LIP. For every incremental change in pressure after the LIP, there's a good increase in volume, with a fair amount of volume for each increase in pressure. Now follow the lower inspiratory curve along to the UIP, or upper inflection point. At the UIP, there is increased pressure with little increase in volume. The balloon is overdistended and at risk of popping. Ventilator PEEP should be set to maximize recruitment and avoid overdistension so that ventilation occurs on the steep part of the curve. This is the stretchiest part of the balloon, where the lung is most compliant. That's the goal. A low tidal volume prevents overstretching the balloon. So how best to do this? There's no one proven best approach, but we'll look at 5 useful methods to choose the correct PEEP, though several have fallen out of favor. We'll tell you why. So how do you choose the right PEEP? Note that for all these approaches, ventilator synchrony is important. This requires adequate sedation or paralysis as indicated. Approaches. Number 1. ARDSNet. This is the easiest approach. MGH often begins with a low ARDSNet table. You put the patient in the correct boxes and increase or decrease the PEEP and FiO2 settings in the boxes. This was arrived at by expert consensus but has not been studied. ARDSNet delivers low tidal volumes at the stretchiest part of the balloon and without straining the wall. This is the most commonly used. Number 2. The best PEEP trial. The goal is to choose a PEEP where the tidal volume is delivered at the stretchiest part of the alveolus without straining the wall. By delivering the same tidal volume with different PEEPs, we can target the most compliant or stretchiest part of the curve. To do this, the patient is usually started at a high PEEP and then marched down. The best PEEP is the PEEP with the highest compliance, the stretchiest part of the balloon. High PEEP can have significant impact on hemodynamics, so close hemodynamic monitoring is required. This chart allows the clinician to monitor all the key variables. At MGH, an RT might start with a recruitment maneuver, a sustained high pressure, but this is reserved for particular circumstances based on expert consultation. A gentler approach is to start at current PEEP, increase slowly with careful attention to compliance until a high enough PEEP is reached that the lung is as recruited as it is likely to get. Then bring the PEEP down by 2 centimeter of water increments, recording PEEP plat at each interval while monitoring SpO2 and blood pressure. The compliance may stay high at lower PEEPs if recruitment has occurred. Then there's some less commonly used approaches. Number 3, stress index. Let's take a look at the pressure time curve. This test is performed with constant flow and tidal volume. An RT generates a square wave flow with the ventilator. Look at the shape of the curve at the very end of the delivered breath. Curve up pressure at the end of the breath suggests overdistension. Curve down at the end of the breath suggests underdistension. Curve flat. The pressure flattens out. The sweet spot of the stress index is a slope about 1.0 and a flat line. Number 4, driving pressure. There is excellent data that driving pressure is important. P-plat is the plateau just after peak inspiration pressure. PEEP, or positive end expiratory pressure, is the final pressure delivered at the end of expiration. The difference between the P-plat and PEEP is called delta P, or difference in pressure, or driving pressure. A key New England Journal of Medicine special article entitled Driving Pressure and Survival in ARDS looked at delta P as a separate parameter from tidal volume in PEEP to see how delta P predicted mortality. The article concluded, we found that delta P was the ventilation variable that best stratified risk. Decreases in delta P, owing to changes in ventilator settings, were strongly associated with increased survival. So changes in tidal volume or PEEP were only helpful if they decreased the driving pressure. Here's an example. 8 cc's per kilogram to 6 cc's per kilogram was helpful only if it decreased delta P. So in this table, delta P minus PEEP generates the most important number as you titrate PEEP. You see the inflection point at this. The goal is to keep delta P below where mortality rate begins to increase. This is the most useful guide, but is resource limited. Number 5, esophageal balloons can be used to measure approximate pleural pressures. This allows clinicians to go a step beyond simple driving pressures and calculate the actual pressure across the lung, known as the transpulmonary pressure. How do you use this to optimize settings? Well, to avoid collapse, you ensure that the end expiratory transpulmonary pressure is sufficiently positive to avoid overdistension. You can vary the PEEP as you would with the best PEEP trial and look for the PEEP that corresponds to the lowest required transpulmonary pressure. Note that the use of esophageal balloons requires some specialized training, and not all centers will have access to the device. So how do intensivists choose? No one knows for certain since there are no head-to-head trials of PEEP titration. However, a key JAMA paper from the writing group for the alveolar recruitment for acute respiratory distress syndrome, investigators did directly compare recruitment with decremental PEEPs versus just using the low PEEP table in moderate to severe ARDS. This randomized trial of 1,010 patients concluded that 28-day mortality was significantly higher among patients treated with a strategy of lung recruitment and PEEP titration, 55.3%, than those treated with a conventional low PEEP strategy, 49.3%. Lung recruitment also decreased the number of mean ventilator-free days, increased the risk of pneumothorax requiring drainage, and increased the risk of barotrauma. The key is that recruitment may not have worked since these maneuvers did not change driving pressures and the recruitment maneuver did not recruit more lung. This leaves open the possibility that there might be a subset of patients for which recruitment used sparingly might be helpful. This paper has caused the open lung approach to fall out of favor, leaving the ARDSNet tables as the suggested approach. Frequent recruitment maneuvers do more harm. So we've seen a terrific set of tools to evaluate your patients. But as a bottom line, what might be the most useful approach, especially in resource-limited settings, is this. 1. Set the tidal volume. 2. Start with a low PEEP ARDSNet table. There's an example in FiO2 of 0.5 and PEEP of 8. Move up or down the table with slow incremental changes, pursuing a satisfactory peripheral oxygen saturation in SpO2 of 90% or PaO2 greater than 55 until a driving pressure of 15 tells you to stop. Plateau pressures less than 30, PIP less than 35, driving pressure below 15. Check the curves on the ventilators. If driving pressures remain above the goal, decrease the tidal volume to 5 cc's or 4 cc's to decrease the driving pressure, accepting that this may result in worsened respiratory acidosis. So the question is, once you have hit a driving pressure of 15, here are the additional measures to consider. Vent synchrony with sedation. This is actually one of the leading problems with COVID patients, and they require a lot of sedation for this. Fluid management. Conservative fluids are better. Proning. This is often recommended earlier in treatment. Pulmonary vasodilators. Inhaled nitric oxide selectively dilates pulmonary vessels in contact with functioning gas-containing alveoli diverting pulmonary blood flow from non-ventilated to ventilated lung regions, improving arterial oxygenation by reducing the intrapulmonary shunt. Paralysis in case of severe vent dysynchrony. Consideration of VV ECMO for the right patient candidate should all these measures fail. Since ECMO circuits are limited, with just 40 for the city of Boston as an example, you want to ask for a consult early if you have an FiO2 of 70 to 90% and are still moving in the wrong direction. We'll consider these measures in additional chapters. Thanks again to Dr. Wong for her terrific efforts and teaching series.